I've introduced myself already. I'm Terry Quinn. At the bottom of the slide, you can see different ways that you can get in contact with me, and I'm always happy to hear from people. And what I'm going to do tonight is tell you about this thing called Cochrane Dementia. So it's sort of customary that you begin any of these talks with what we call our disclosures. People tell you about the funding that they've received. So I'm a researcher as well as being a clinician in the NHS. I've had funding from all of the bodies that you see there, particularly the Chief Scientist Office and the Stroke Association. So that's my disclosure. But I guess for this talk and for this audience, I've got some other things that I have to disclose, some other confessions to make. So Craig Ritchie, who's the chair of the SDRC, asked me to give this talk, and he said, Terry, can you talk about Cochrane systematic reviews and the dementia reviews that you've been involved with? And of course I said yes. You don't say no to Craig Ritchie. But I do have confessions to make, and confession number one, which will be obvious to anyone that knows me, is I would never call myself a dementia expert. I'm a clinician. I work in geriatric medicine and older adults in the NHS. I don't run a memory service. But sometimes I think that's maybe a good thing, because by not being a card-carrying Alzheimerologist, it means I can sometimes challenge some of the accepted wisdom and some of the dogma that there is in Alzheimer's research. But I've got more than one confession to make. I also have to confess, although I'm going to be talking about this entity called Cochrane, which I'm very much part of, Cochrane is so big and changing all the time that there are some aspects of it even I don't understand. So there are certainly bits of Cochrane that are not so familiar to me. For this talk, we're going to very much focus on my group, which is the dementia group. And I've got a third confession to make, which is, although Craig asked me to just talk about Cochrane, I'm going to talk about some of the other evidence synthesis type projects that I've been involved with that aren't necessarily Cochrane product, but that have very much been informed by my experiences in Cochrane. So we've got those confessions out the way. Here is my plan for tonight. Because this is a mixed audience and some of you might not even know what Cochrane is, I'm going to start off with a bit of a primer on Cochrane and its history. I'm going to show you what we make in Cochrane, which is reviews, and talk you through what those reviews look like. And then I'm going to finish by talking about my group, the Cochrane Dementia group, and just talk about some of the reviews that we've produced, my personal favourite reviews. So let's start with a brief history of Cochrane. And we're going to go back in time. We're going to go back in time to the 1980s, which was really a time when this concept that we now call evidence-based medicine was in its infancy. And the man you see in the photograph there, Archie Cochrane, made a very prescient observation, which is possibly still true today. And that was that in medicine, a lot of the things we do have no science to back them up. And that means that some of the things we do might be harmful. And his solution to that, which was transformative at the time, was we need a way of bringing together all of the science, all of the randomized controlled trials, in a way that can critically synthesize those trials to give a result that clinicians can use. And that was the genesis of Cochrane. So in the mid to late 1980s, this entity called the Cochrane Collaboration was formed. It started off just looking at perinatal medicine, but then it spread to lots of other aspects of medicine, including dementia. And when Cochrane first started, there were three core aspects to it, and they remain core aspects to Cochrane even now in the year 2021. So the first thing was they created a register of all of the relevant randomized controlled trials, and that's something that we still do. So within my Cochrane Dementia group, any randomized controlled trial in dementia that's published, we bring into our database, so it's there for us to extract data from. The next thing that they did in this early incarnation of Cochrane was they worked on statistical techniques that would allow you to take lots of different trials and create a summary from them. Those techniques became what we now know as meta-analysis. And then the third part is they realised that they couldn't just do this on their own. They needed a team of people, often volunteers, often clinicians, and that was the collaboration part of the Cochrane collaboration. And it remains true today that Cochrane is mostly staffed by people that voluntarily give their time, and they're often clinicians. So from those beginnings in the 1980s, Cochrane, which is now just called Cochrane, not the Cochrane Collaboration, has become a huge beast. It's produced over 7,500 systematic reviews in 14 languages. From that one group based in perinatal medicine, it's spread out to have 53 different groups with 30,000 volunteers working for Cochrane. The main vehicle that Cochrane publishes its work is in a journal called the Cochrane Database of Systematic Reviews. And for those academics who are interested in impact factor, the latest impact factor for the CDSR is close to 8. So it's kind of mid-range general medical journal. So within the umbrella of Cochrane, there are lots of different groupings. There are groupings specific to certain methods, there are groupings specific to certain geographies, and there are also groupings specific to certain conditions. And the group that I work with is this group here, the Cochrane Dementia and Cognitive Improvement Group. And that's the group that we're going to be talking about. I'm just seeing, Carleen, if you're still there, I'm just seeing out the corner of my eye, a little message has flashed up saying that there are people waiting in the lobby. I don't know if you're able to let them in or not. Okay, so let's talk about this Cochrane Dementia and Cognitive Improvement Group, my group. So it was formed in the mid-90s. Like many of the Cochrane groups, it's based in Oxford in the UK. And a while ago, as a registrar in training, I won a scholarship to go down to Oxford and to work with Cochrane Dementia. And I was expecting what you see in the picture. I was expecting the ivy and the Gothic and the spires of University of Oxford. In fact, I ended up in a little office in this building, which is the John Radcliffe Hospital. So it wasn't quite what I was expecting, but actually it was great. And I guess I must have done something right, because from those few months spent working there as a trainee, I've continued to work with the group, and I help manage the group. So here's the core team in Cochrane Dementia. I'm there as one of the coordinating editors, and I share editorial duties with Jenny McCleary, who's an old age psychiatrist. And I think that duo of someone coming from a geriatric medicine background and someone coming from an old age psychiatry background has worked really well, because we bring different expertise. We've always been very passionate in Cochrane Dementia about representing all of the disciplines that might be involved in dementia care. So our deputy editor is Sasha, who's a nurse from Cologne in Germany. When you're dealing with lots of trials, potentially hundreds or thousands of different trials, you need people with expertise to help you. And so we have two information scientists, Anna and Candida, who you see in the pictures there. And for any big group, you need someone to actually do the day-to-day management. And that's done very ably by Sue Marcus, who's in the picture here. I couldn't find a more recent picture of Sue. She is a little bit older than in this photograph, but nonetheless, there is Sue there. So this is the core team of Cochrane Dementia. I'm based up here in Glasgow. Jenny, Sue, Anna and Candida are all in Oxford, and Sasha is in Germany. And beyond that core team, we have a more extensive international editorial board. I don't have space on the slide to give you little thumbnail pictures of everyone. So here's just a selection of some of the people that we have as our editorial board. And you can see we've got people from different parts of the world. And we've got people that bring different expertise. So Najma is very much interested in delirium. Although our title is Cochrane Dementia, we include reviews on topics like delirium, traumatic brain injury. And we have people that come with different methodological expertise. So Claire Sir very much comes from a qualitative background, whereas, for example, Lon Schneider from the USA is very much a trialist. So lots of representation there of different groups that are important in the dementia space. And again, if you're interested in things like impact factor, the impact factor of the publications from our group comes in again at quite close to 8. So really not bad. Impact factor is one way at looking at whether an academic group is having impact. There's other ways of looking at that, and I just thought I'd share some of them with you. So you might want to look at how often do people read the reviews that you produce. So here we have all of the different Cochrane review groups, and our dementia group is up at the higher end. You know, on average each year, about 700 people are accessing our work. So that's really not bad at all. It shows that people are interested in what we are producing. A real marker of whether the reviews you're producing are making a difference is whether they're used in guidelines. And again, you can see for our group, each of our reviews is cited in an average of 3 different guidelines. So clearly the reviews that we are producing are having an influence on practice. And if you're more interested in things like social media, you might want to look at things like altmetrics. Altmetrics is how often Cochrane products are blogged about or tweeted about. And our altmetrics are really, they're pretty impressive. And within this top 10, one of our dementia reviews is in there, a review on memantine for dementia. So far, hopefully you're impressed. Hopefully you think this Cochrane thing seems like a good thing. But more recently, there has been a bit of a concern about Cochrane and about systematic reviews. And I've got here some text from an editorial that was published in the Millbank Quarterly. It was a few years ago. It's worth reading the whole thing, but it's very scathing of systematic reviews. And I've just highlighted some points here. It talks about this industry that's been formed around systematic review. And it recognises that now there are actually more systematic reviews being published than there are trials being made. But a systematic review only exists to pull together trials. So there's a disconnect there. It recognised that with there being so many systematic reviews, there was a huge amount of overlap, and actually most of these reviews were redundant. They didn't need to be created. There was real concern that some of these reviews were being produced by people that were conflicted, perhaps people that worked for the drug industry. And there was also concern that many of these reviews methodologically were simply flawed, or they were weak, and they could never give any evidence that could change practice. And the sign-off from this editorial was that most systematic reviews and meta-analysis were unnecessary, misleading, and conflicted. Ouch. Difficult to hear if you work in systematic review. So are Cochrane reviews guilty of those things? Well, let's just have a think. Are our Cochrane reviews conflicted? Well, I think I can fairly safely say that they're not. Cochrane has a very robust conflict of interest policy. Some people say it's too stringent. So, for example, if you were an author on a review that might be included, on a paper that might be included in a review, you couldn't be part of that review. That's how much we have concern over conflict of interest. Are our reviews misleading? Well, again, I would hope not. We are really very hot on methodological quality, quality control. There are lots and lots of levels of peer review before a Cochrane review is released to the public. So I would hope that we're not guilty of that. Are our reviews unnecessary? Well, perhaps, and perhaps historically they have been. But more recently, we've been really working to try and prioritise the reviews that we do. So we're only producing reviews on topics that are going to be important to people working in dementia. And things change all the time. And Cochrane Dementia is going to change. I've got here pictures and quotes from two people who were in charge of the funding of Cochrane Dementia and other UK Cochrane groups. And several years ago, we were told that Cochrane Reviews had to up their game. They had to become more complex, and we did try to do that. This year, Professor Ken Stein has said he wants to see change, and the size and the shape of Cochrane Review groups that are funded in the UK is going to change. Now, as I speak to you today, the truth is we don't know what that change is going to look like. These are uncertain times for Cochrane Dementia, but there will always be a space for a group that brings together research and tries to create a synthesis of it. So hopefully now you understand a little bit about the background to Cochrane. Let's look at Cochrane product and let's look at a Cochrane review. One thing that a lot of people ask me if they want to get involved in Cochrane is, how long does it take to make one of these Cochrane reviews? And actually, I've got a little cartoon here of how long it takes to do any kind of collating of science. And there's a trade-off. There's a trade-off on the work that you have to do and how valid the review you produce is. So if all you want to do is find a single paper that answers a question, that takes no time at all. If you want to pull together 3 or 4 papers on a topic so that you can give a talk on it to your colleagues, that takes a little bit more work, but not too much work. But if you want to pull together every paper on a topic and create a synthesis of them that's fair and transparent, that takes a lot of work. And it's estimated that a team of experienced researchers working full time would take at least a year to create a systematic review that's of a quality that it could be published. I mentioned before that in Cochrane, we are very, very hot on methodological purity. And as a result, the time it takes to create a Cochrane review is even longer. And some people might say it's almost infinite, because it sometimes seems like we never get our reviews published. So what goes into that Cochrane review? Well, the Cochrane review and any kind of systematic review has at its centre a question. And then to answer that question, you have 3 components that are equally important: a search of the literature, a critique of the papers that you find, and some way of collating those papers together. So let's start with the question. And the best questions, and the questions that we always encourage in Cochrane, are questions that come from the clinical community, questions that come up in your day-to-day practice. So for example, a question that a lot of people working in dementia might be asking at the moment is, should I be giving aducanumab to my patients? Now that's a good question, but it's not a question that could be the basis for a review. And one of the first steps in a Cochrane review is to take that rather unfocused question and structure it in a way that allows for a systematic review process. And we do that by breaking it down into 4 components. So we break the question down into who are the participants, what is the intervention that you're interested in, what is it being compared to, and how are you measuring success? What are the outcomes that are being assessed? And this is called PICO, P-I-C-O. So we can apply PICO to this question of, do I want to give people aducanumab? And as we apply it, you start to see that it's not as straightforward as you might think. So if we ask the question, well, which patients are we interested in here? You might say, well, we're interested in patients with dementia. But are we only interested in them? And are we interested in a group of patients with dementia? You might want to say, well, actually, I'm only interested in people living with Alzheimer's disease. And even within that group, actually, perhaps you're only interested in people that have mild dementia due to Alzheimer's disease. And you might be interested in an even more niche group. You might only be interested in those people who have mild Alzheimer's disease dementia and have positive biomarkers, because that's the group that were included in trials. What's the intervention? Well, again, at a simple level, you might say the intervention is aducanumab. But are we looking at high or low dose? How many administrations? What's the route? You have to think of all of these things and pre-specify them. What are we comparing to? Usually in randomized controlled trials, the comparator is a placebo, but increasingly we don't use placebos because there are already best practice recognised treatments that you need to compare with. So for aducanumab, you might want to compare with another monoclonal antibody. And you might want to ask, should everyone be on a cholinesterase inhibitor or not? And then perhaps most difficult of all is to choose, how do you measure whether the aducanumab is actually working? What is the outcome that you want to look at? You could look at, for example, a measure of cognition, but which one? There's thousands. You could look at a measure of day-to-day function, but again, there's so many of them. Which one do you choose? Maybe you look at both. Or maybe you look at other things that we know are important to people living with dementia, like how many people end up in a care home. Or maybe you want to look at adverse effects and side effects. All of them are important. And in fact, often in a Cochrane review, we look at more than one outcome. We often have outcomes that look at whether the drug works and outcomes that look at harms. So once you've defined your question, you then have to think about searching the literature to find the papers that are going to answer that question. And again, that's not easy. And it's not easy because there's been an absolute explosion in the biomedical literature in the last 10, 15 years. So in January last year, the database of papers called PubMed had over 30 million scientific papers. And in fact, in the last 10 years, almost 1 million new papers have been added into PubMed, and that's a number that's increasing all the time. So with so much science out there, how do you search it? Well, that's an area where Cochrane's actually been doing a bit of work. I showed you this cartoon before. One of the reasons it takes so long to do systematic reviews is to go through that literature searching process. And I can tell you it's the step of a systematic review that no one enjoys. But does it have to be that way? Here's a intriguing, slightly controversial paper that was published quite recently. And it showed that if you use artificial intelligence and if you use other technologies, you can go from having to take years to do a systematic review to being able to do a systematic review in 2 weeks, which is a huge change. And if other groups are able to do that, it's going to completely change the way that groups like Cochrane work. So that was making systematic review easy using technology. Another resource that you have are people. And in Cochrane Dementia, we've been working with crowdsourcing. So we ask volunteers to do some very light touch training with us. And then we ask them to do a little bit of searching of the literature. We send them maybe 5 or 10 papers to work through and to tell us whether they're relevant to a question. And so in the Cochrane crowd, we have almost 22,000 volunteers, and it means that you can get through thousands of scientific papers really quickly, just by farming out a few at a time to this large group of people. Okay, so let's say that we've searched the literature, we've identified papers. The next thing you have to do is you have to critically look at those papers. Just because something's been published, that's no guarantee of quality. And in fact, a lot of published science has really major methodological flaws. So in Cochrane, we've created a checklist for looking at trials, and we look for these different biases. And there are biases around things like, how were people selected into the trial? If the trial was a randomized control trial, how was the randomization done? Did the person looking at outcomes know whether the person that they're assessing was given the drug of interest or not? A thing that we call blinding or masking. And so we apply this checklist to every paper that goes into our review. And we often use a traffic light system where green says that we have no concern about bias, red suggests that we have a concern, and amber means we're not really sure. And here is the risk of bias assessment for one of our recent papers looking at drug therapy for sleep disturbance. And you can see most of the papers were okay, but there were some aspects of papers where we felt there were questionable methods or there was this risk of bias. And then the last step, once you have all your papers, once you've critically appraised those papers, is to try and pull them together to create some kind of summary. And this is where people can be confused, because they think that a systematic review has to include meta-analysis, or they think that systematic review and meta-analysis are synonymous, and they're not. They're two separate methods. Systematic review is a method for bringing together all of the science on a particular topic or question. Meta-analysis is something distinct. It's a mathematical procedure that allows you to combine information. So they are distinct, but they can often complement each other. Because if you've found lots of different papers that have data, you can combine them together to give one overall summary of how that thing may work. And the way we do that is with this graphical representation that we call a forest plot. So here we've got a forest plot. It's looking at the drug memantine in Alzheimer's dementia, and it's looking at an outcome of a global outcome, a global assessment. And we can see here each individual study that looked at memantine in Alzheimer's dementia. And for each one, there's a little dot that is how well it works, its effect. And then the line is our uncertainty about that. Here we have a line of no effect. Any dots on this side of the line would suggest that actually the drug doesn't work at all, as placebo is better. Any dots in the middle would say there's no difference, and any dots on this side would say that the drug memantine is better than placebo. And what you can see is for each individual study, although the dots all tend to be on this side of the line, the uncertainty is often large, and it crosses this line of no effect, which means you can't be sure for each of these individual studies whether there is a real true effect. But in meta-analysis, we combine all of these into one summary estimate. You can see there's now, we don't have these lines of uncertainty. By pulling things together, we've improved precision, and it becomes very clear that the effect of memantine is separate from this line of no effect. Memantine is having a beneficial effect, and that's what our review says. But you don't stop there. The meta-analysis is only part of the overall summary. The real question that clinicians have is, you've given me a meta-analysis, but am I confident that that's real? Am I confident that that's true? And so the final step in Cochrane evidence synthesis is to apply a thing that we call the grade framework that tries to answer that question about the certainty of the evidence. And in applying grade, we look again at the risk of bias for all the included studies. We look at how precise the result is, but we also look at things like, is there inconsistency between those included studies? We ask, could there be any bias in the publication? And we ask, do those papers that we found really answer the clinical question? And we take all of this together to create what you see here, which is very much the central piece of any Cochrane review. It's what we call our summary of findings table. So here we have a summary of findings table for the question, does memantine compared to placebo in people with moderate to severe Alzheimer's disease make a difference? And you can see the outcome was this global scale. There was a difference there, and the certainty of that evidence we felt was high. So we can make a fairly strong recommendation that memantine does seem to make a difference in moderate to severe Alzheimer's. Okay. So now you're familiar with the history of Cochrane. You know a little bit about what a Cochrane review looks like. I want to use the last 20 minutes to just show off some of my favourite Cochrane reviews from our Cochrane Dementia group. So for those of you of a certain age, you'll remember Top of the Pops. Top of the Pops used to give a top 10 rundown of the biggest selling pop singles, and they would be included in these albums that had garish covers like this. So Cochrane is all about objectivity. What I'm going to do is completely subjective. I'm just going to give you a few slides on 10 of what I think are the most interesting reviews that Cochrane Dementia has produced. And let's start. And my number 10 are reviews looking at drugs, which perhaps is what Cochrane is best known for, systematic reviews of drug therapy. So here's one from the vault. This is one of the very first Cochrane Dementia reviews looking at Cochrane, a drug that works according to the cholinergic hypothesis. It's not used anymore. And here we see the summary of that review. And a lot of the bits there are still what we'd see in a Cochrane review that we produce today. You have a very clear question, a clear objective, and a method that's been published in a protocol. You have this very systematic method of searching the literature to make sure that every relevant paper is found. All the aspects of the review are conducted by two people independently, and that's a safety net. If one person misses something or makes a mistake, it gets picked up by the other. And you can see here in this text the synthesis of the evidence. And it speaks about the pre-specified outcomes. It includes a meta-analysis. It looks at benefits and harms. But there are some things that are missing. We don't really have an assessment of bias in this historical review, and they've not used the grade criteria. So some things have progressed over time. So let's fast forward to one of our more recent reviews. It's one that you've seen before, this review on memantine for dementia. And it's got all the things you would expect in a Cochrane review. We have this very detailed description of the papers that were included and how we found them. We have our forest plots looking at the effect of the drug, and we have the traffic light system assessing the bias or the quality of evidence for each of the papers, and we pull it all together into this summary of findings table that gives recommendations. But we don't stop there. When we have a review, we want it to reach the broadest audience possible, not just clinicians, not just academics. So you can see here on this screenshot from the Cochrane website for our memantine review, you can watch a video about it, and there are podcasts about it, and you can read the review in lots of different languages. And we really want to try and democratize the research and make it available to everyone. So that's a review of a single drug. The drugs that are most used in Alzheimer's disease dementia are the cholinesterase inhibitors, donepezil, galantamine, rivastigmine. We had reviews of each of those drugs individually, but the question that clinicians had wasn't, do these drugs work? It was, which drug is better? Is there one drug that I should use in preference to another? And so that's something that we've answered recently. And we did that by doing a thing called a network meta-analysis. So rather than summarising how one drug works in isolation, we use statistical techniques to directly and indirectly compare how drugs might work if they went head to head. And we create this little network that allows you to compare different drug options. And then you create a chart, and you can see that if you're looking at effect on cognition, if you compare these different drugs, this is for the indication of vascular dementia, donepezil 10 milligrams seems to work best, rivastigmine maybe not so much. And we did exactly the same thing to look for side effects. And you can see donepezil at 5 milligrams seems to have the least side effects. Other agents had more. And more recently, we've become interested not just in reviews that look at new drugs and adding drugs, but reviews that look at taking drugs away or deprescribing. And we've got 2 reviews looking at stopping drugs in people living with dementia, but it's an area where we're going to have more reviews very soon. So that's drug reviews. What about non-drug reviews? Well, we've got some of them. Actually, some of our most downloaded content is for non-drug interventions in dementia. Here's one which looks at aromatherapy. You can see the summary of findings table here looks quite different. We don't have lots of meta-analysis because all of the different trials and studies were just too different. It would have made no sense to pull them together. So rather we have a text giving a narrative about the different papers that we found. But that doesn't mean that non-drug trials can't be included in a meta-analysis. They absolutely can. And here's one of our most recent reviews. And this is looking at interventions to prevent delirium, non-drug interventions. And you can see the forest plot here, and you can see that in people in medical wards, people in surgical wards, you can definitely prevent delirium. And here's our summary of findings table here. We have moderate certainty evidence that non-drug interventions can stop people from developing delirium. So that's a big deal. And that's something that's already being incorporated into guidelines. But again, we weren't content with that. We wanted to know more. What we knew from that review was that multi-component non-drug interventions could stop people getting delirium, but we wanted to know what the components were. We wanted to open up the black box and not just say that if you do lots of things that can stop delirium, we wanted to know which of those things worked best. And so we did some more sophisticated analysis where we looked at the components of interventions in each of the included trials and were able to work out which ones seemed to be driving any benefit. And here's what we found. We found that things like cognitive stimulation, sleep hygiene seem to be very important for preventing delirium, whereas other things maybe not so much. So those are interventions, but we don't only look at interventions in Cochrane, we also look at diagnosis. And you might think, well, diagnosis isn't very important in dementia, but actually, for lots of aspects of clinical practice, we're looking at diagnosis all the time. So you might be doing a screening test and you want to know whether it works. Or you might want to order an investigation to make a diagnosis clinically. Or you might want to look at a biomarker. All of these things are asking the question, what is the accuracy of a test? And you can see here the format that we use for asking those questions. So here is a test. It's called the AD8. It's a screening test to look for dementia. It asks 8 different questions. It's used a lot in North America, so we wanted to know if it was any good. And so we published a review looking at that. And what we have here is a different kind of plot. This is a plot looking at accuracy. It's looking at, can the test pick up people that do and don't have dementia? Each little circle here is an individual paper, and the black circle is a summary, pulling all of those papers together. And lo and behold, it looks like this AD8 test actually works quite well for making a diagnosis of dementia. And we then create, again, a summary of findings table that describes all of that and also gives some pointers on how to use the test in practice. But again, we weren't happy just with that. We were always pushing the methodological envelope. What we had was a method for looking at the accuracy of individual tests. But again, in practice, the question that's often asked is, which test is best? If I have lots of tests available, which one should I choose? And so we've developed a statistical method around that. We've developed, similar to the network that I showed you for comparing drugs, we've developed a method that allows us to create a network of tests and compare one against another and start to rank them and say which one is or isn't best. So let's move on now from diagnosis to prognosis. And again, you might say, well, what's prognosis got to do with dementia? Well, actually, it's a thing that's on everyone's mind. If you look at newspaper headlines, they're always telling us about something that seems to cause or predict dementia. And prognosis research is a research method that's sort of come of age, and there's been a lot of interest recently in trying to improve how we do prognosis research. And if it's something that you're interested in, I'd very much recommend this website here, which is very much your go-to guide for how to do prognosis research well. So how do we do prognosis research in Cochrane? Well, there's 3 different kinds of reviews. We can do what's called fundamental prognosis, which asks the question, what is the natural history of, for example, Lewy body dementia? Or we can look at prognostic factors. So we ask the question, does exposure to a thing, for example, air pollution, cause dementia? Or we can look at models that combine lots of different factors to try and estimate someone's risk of dementia. And we can do reviews in all of these areas. Here's an example of a prognostic factor review. Here we looked at whether drugs that have anticholinergic properties seem to be associated with developing dementia. And here's the summary of findings table, and the answer is they do. There seems to be more than a doubling of risk for developing dementia if you're exposed to anticholinergic drugs versus not being exposed. So I want to move away from reviews and just talk about some of the other things that Cochrane does. And one thing that we do, it doesn't win us a lot of friends sometimes, is we are critical when we feel that we have to be critical of dementia research. And let me give you an example. Here is the picture that's in almost every dementia talk that's ever been given. It's by Clifford Jack, and it shows this theory of Alzheimer's that people have A beta abnormalities in the brain first of all, then with time they develop intracellular tau abnormalities, then with time they have neurodegeneration, and then much later they have memory and thinking problems, and much later again they develop the thing that we call dementia. In Cochrane Dementia we had no problem with this. This seemed to make sense. But based on this, people started to say, well, if you can measure amyloid, or if you can measure tau, you'll be able to say who's going to develop Alzheimer's disease. And we weren't sure that that was right, or at least we weren't sure it was correct based on the evidence available at the time. And so in Cochrane style, we pulled all of the research together, and actually we found that when you move away from all the hyperbole and all the enthusiasm, the science was imperfect, and the science of biomarkers for detecting and predicting dementia really wasn't great. That was a few years ago now, and biomarkers have moved on a lot, but they're still not perfect. And this is a review that we published last year that again shows biomarkers are not the only way to diagnose dementia, and actually there are limitations when you try and use biomarkers to make a diagnosis. In a couple of the slides I've shown you, I've been talking about methods. Apologies, I'm a bit of a methods geek. And one of the things that I've liked about being involved with Cochrane is we've been able to develop methods, as well as being part of Cochrane and part of an NIHR group that has a remit around developing methods for systematic review. So for example, this network meta-analysis that I showed you is a very useful method. The stats underneath it are more complicated than a lot of people might be comfortable with. So we created an app. It's a free app. The URL is there if you want to use it. And it allows you to perform a network meta-analysis without having to understand the complex stats that are happening under the bonnet. Here's a slide that I showed you earlier looking at a meta-analysis of accuracy studies. And again, the statistics to allow you to create this are quite complicated. So we made an app, and the app is free. The URL is here, and it allows you to create those summary estimates without having to use very specialist statistical software. In Cochrane Dementia, we're all about methodological quality. We're all about evidence-based medicine. So one of the things that we do and we continue to do is we try and raise standards, and we try and promote evidence-based medicine in dementia. And to do that, we've done various things. We've created guidelines to help people when they're reporting research. We've created templates and checklists for people if they want to perform systematic reviews. And we've created lots of educational materials, and that's a thing that we're going to continue to do so that everyone can produce the best quality and the most robust dementia research possible. So everything so far has been dementia. Let's take a little digression. I think it's impossible nowadays to have a talk that doesn't mention COVID. During lockdown, when a lot of people had a bit of spare time, some of the Cochrane Dementia authors that I work with came together with me to work on a project that looked at COVID. Because we were hearing that COVID was based on science. We were following the science we heard. So we had a look at that. And what we did was we looked at all of the trials looking at treatments for COVID that were published in the first part of lockdown. So, in the first part of the year 2020. So we had studies from the big journals, the New England Journal, the Lancet, the BMJ, JAMA. And here's what we found. Here are the different kinds of studies that can be published in a journal. Usually in big, high-profile journals, they publish randomized controlled trials. But what we found for COVID is that actually these big journals were publishing case reports or case series, which are always a lower form of evidence. So we then compared the COVID papers to the standard papers which weren't looking at COVID. And again, we found differences. The COVID papers were much smaller in their sample size. They had much shorter follow-up. They were more likely to be retracted. And when we looked at quality, they were more likely to be at risk of bias and they're more likely to have poor reporting. And it doesn't have to be that way. People said to us, this is unfair. You're in a viral pandemic. You have to work with whichever science is available. But we would make the argument that actually you should invest the time to do things right, and you can do that. And there's great examples of that in the UK. For example, the recovery study, a huge trial, but it was able to complete very quickly. And it was able to give us good quality evidence for things that work and things that don't work in COVID. So we're almost done. There's just two last things that I quickly want to talk about. And one is about prioritization. It's about how we choose in Cochrane the reviews that we want to do, because there's lots of questions. There's lots of reviews we could do. Traditionally, we looked at what had been most popular before. So we looked at which of our reviews were being cited or were being used in guidelines, and we used that as a thermometer for the future reviews that we should do. But actually, there are other ways to look at prioritization. And there had been lots of papers published that had asked people living with dementia, that had asked caregivers what their priorities were for dementia research. So in Cochrane style, we did a review of those and we pulled them all together, and here's what we found. We found that the main priority for research was questions around caregivers and questions around supporting people living with dementia. And those aren't areas that actually we've traditionally spent a lot of time on in Cochrane Dementia, and that's where we're going to invest a lot of our effort. And another thing that I thought was interesting was the topics that were prioritised seemed to differ across the world. So in Europe and North America, caregivers were prioritised as a thing in dementia that needed more research, whereas in Asia and India, awareness and education around dementia was prioritised. So last but by no means least, number one in my Cochrane top 10 isn't a review, it isn't a method, it's about people. Because more than anything else, I think the important thing that Cochrane Dementia has done is it's supported lots of people, lots of researchers. It's gave them an introduction to research, it's gave them training, and many people have went on to bigger and better things having worked with our Cochrane Dementia group. And I just have a small selection of some of the people that have worked with Cochrane over the years, and they're from lots of disciplines, from science, from clinical medicine. They're from different places, from across the UK and elsewhere. As I said before, one of those people was me. Many years ago, I travelled down to Oxford to spend some time with Cochrane and have not looked back since. So I guess that's my favourite Cochrane output is our support of people. So I have gave you a whistle-stop tour of the history of Cochrane. I've gave you a bit of a primer on what a Cochrane review looks like. And in a very unevidence-based way, I've gave you my top 10 things that Cochrane has produced. And that's where I'm going to stop talking. I've went on a bit, I know. I often do that when I'm passionate about a subject. So we have a little bit of time for questions. If you don't want to ask questions tonight and it is getting late,